My name is Dr. Asif Khan, and today I'm going to talk a bit about the disorders of ankle and foot. Um, as you can see on the top left side of the picture, there are different kinds of feet we come across in our daily lives. There are different shapes and types of deformities well appreciated in this picture. While on the bottom right side of the picture, you can see different footings while we walk. Uh, this is called a gait cycle. Gait cycle normally comprises of two phases: the swing phase and the stance phase. 60% of our gait constitutes stance phase, while 40% is a swing phase. In stance phase, it's further divided into three intervals. As you can well see in the picture, the heel strike, when your heel strikes the ground, and then there is a flat foot, and when your body shifts over ankle, and the fourth one is toe off. So these are the different intervals of stance phases. There is an interesting picture on the left side of your screen. It's obtained by a subject walking on with his right foot at self-selected speed across the pressure platform. A pressure distribution with 8 discrete transducers were used to record these pressures, and it's a real-time biomechanical motion analysis. Uh, in the middle image, you can see a swinging pendulum, where the ball of the pendulum represents the foot, while the stable dot overhead represents the stable pelvis. It means a stable pelvis is necessary for a flawless, smooth walking. And then there is a first foot of a human on Mars, Neil Armstrong, on Moon, sorry. Neil Armstrong's foot when he landed on the moon surface. There are degrees of flatness of foot well appreciated in these pictures. Uh, Mild, moderate to severe. From left to right, it's severe, moderate to mild form of flatness, and then there is a normal arch position of the arch, and then there is a high arch, uh, and then there is the severe overpronation, severe inside wear of the shoe, causing by these flatness of the foot. Uh, on the in the middle picture, top side, you can see new heels and worn out heels, different position of the foots on the now. The most common deformity one can encounter in foot is helix valgus. It's very much common, and in our daily lives and in your setting and outdoors, you come across different kind of helix valgus. It's a deviation of the big toe away from the midline, that is towards the lesser toes, and it's usually associated with bunion. And it is caused by narrow toe shoes and some pathological conditions like rheumatoid arthritis is one of the culprits which causes helix valgus, and it is due to weakness of the joint capsule and ligaments. And with the increasing deformity, the first ray becomes defunctioned, and overload of the second metatarsal joint results in pain and swelling with prominent callosities beneath the second metatarsal joint and eventually hammering of the second toe. Hereditary plays an important role in the development of helix valgus, as 60% of the cases has been associated with positive familial histories. Uh, on X-ray, you can see the angle, intermetatarsal angle between the first and second metatarsal. It's a deviation. You can see there the deviation is quite drastic. So these are some images which are showing the normal to abnormal curve, and these are different kinds of treatment where we uh, osteotomies are done. These are again different pictures and outcomes of these operations. Clinical feature. The commonest complaint, as we all know, is the pain, especially over the bunion. And bunion, as we all know, is callosity, formation of callosity bone, and soft tissue formation is called bunion. Um, at times, female patient worries about their cosmetics, their looks, and they also complain about the fitting of their favorite shoes. Often there is a deformity of the lesser toe and pain in the forefoot as well. Always check the circulation and sensation in these kind of deformities. For mild deformity and distal osteotomy, chevron osteotomy is usually advocate. For moderate deformities, the surgeon is more likely to use a shaft osteotomy. Treatment, many young patients are asymptomatic. They do not need any kind of treatment, but worried over the shape of the toe and the anxious mother or parents keen not to let the condition become as severe as her own. So this consists essentially of encouraging the patient to wear shoes with wide and deep toe boxes, soft upper and lower heels. Trainers, joggers, sneakers are a good choice. Again, second condition, which is not that common, but it is there. It's called helix rigidus. Helix rigidus is a stiffness. Rigidus means stiffness of the first metatarsal. It's a painful condition of the helix metatarsophalangeal joint, characterized by loss of motion, especially in dorsiflexion, and osteophyte formation on the dorsum and side of the joint. It can occur at almost any age, from adolescent onwards, especially. In adults, there is often a history of trauma or repetitive microtrauma, sports injuries, that is, but occasionally there is a strong familial history of the condition present there. Um, as we all know, young people they are more energetic. They have their physical activities there. So the local trauma and osteochondritis dissecans of the first metatarsal head plays a role in developing of helix rigidus. In older people, somehow it is usually caused by long-standing joint disorders such as gout, pseudogout, or osteoarthritis for that matter, and is often bilateral. Clinical features. As we all know, it's a painful condition. Pain presents on walking, especially on slopes or rough grounds, is the predominant symptoms. Uh, Patients somehow developed a deviant or altered gait, trying to offload the first metatarsal joint by transferring their weights across the lesser toes. It's very much common. A greater toe is straight and often has a callosity under the medial side of the distal phalanx. The metatarsophalangeal joint feels knobby, a tender dorsal bunion, Actually, a large osteophyte is diagnostic. X-ray shows narrowing of the joint space. Subchondral sclerosis, there is a subchondral sclerosis evident, and marginal osteophyte formation are always there in helix rigidus. So what should be the treatment in this condition? If the condition is not interfering with daily activity, then it can be left alone and patient can be reassured. Corticosteroid and local anesthetic intraarticularly has shown to relieve the pain in intermittent attacks. Role of orthotic devices, rocker soled shoes are also there to help in relieving the pain. Kylectomy coupled with an extension osteotomy in the proximal phalanx is also a choice, can be done with good results. Fusion or orthodesis offers a good chance of returning the patient to near to normal functional life. Orthoplasty can be done, but the role is quite controversial. And there are namely two operations are there, Keller's operation and interposition orthoplasty. Now, deformities of the lesser toes. The commonest deformities of the lesser toes are claw, claw toes, hammer toes, and mallet toes. Claw toe is characterized by hyperextension at the metatarsophyllangeal joint and flexion at both interphalangeal joints, while hammer toe is an acute flexion of deformity of the proximal interphalangeal joint only. Mallet toe is a flexion deformity of the distal interphalangeal joint. So there is a small difference between hammer and mallet toe. One is proximal interphalangeal joint, while the other is distal interphalangeal joint. These are, you can see that this is a picture of a claw toes, while this is a hammer toe. Tendon disorders in the ankle and feet, Achilles tendonitis is also one of the common pathology, can be observed and seen in different kind of people, especially athletes, joggers, and hikers often develop pain and swelling around the tendo-Achilles. It's due to local irritation of the tendon sheath or the paratendon. It usually affects the watershed area. That is, the watershed area is about 4 centimeter above the insertion of the tendon. It's an area where the blood supply of the tendon is poorer than the elsewhere. So the tendon sheath or the flimsy tissue around it may become inflamed. Tendon, it also affects at the tendon insertion. Retrocalcaneal bursa and spontaneous rupture can result from long-standing Achilles tendonitis. So, what can be the features of Achilles tendonitis? The condition may come or on gradually. It presents gradually or rapidly following a change in sporting activity or change of sports footwear. Direct trauma to the Achilles tendon also causes Achilles tendonitis. The area above the heel may look inflamed and function is inhibited because of the pain in the heel cord, especially at push off or toe off. The treatment constitutes rest. The mnemonic is RICE, rest, ice packing, compression, and elevation. And the use of NSAIDs, oral or topical, are shown to alleviate the pain. Stretching exercises are also beneficial. Muscle strengthening programs should be initiated after pain subsides. Removal in shoe heel raise can be advised. Orthotics has a role in treating Achilles tendonitis. Operative treatment, decompression operation can be used as a last resort in long-standing Achilles tendonitis. Traction epiphysitis or Sever's disease is a condition usually occurs in early teens, especially boys, and it is not a disease but a mild traction injury of the epiphysis. Kohler's disease, osteochondritis of the navicular. The bony nucleus of the navicular becomes dense and fragmented, or as you can see in these x-rays, it's quite dense and fragmented. The child under the age of 5 has a painful lump and turned worm thickening over the navicular. Can be seen in this image. No treatment usually is required for Kohler's disease. It resolves spontaneously, but it can present to you in your outdoor settings. Freiberg's disease or osteochondritis or osteochondrosis of a metatarsal head is probably a type of a traumatic osteonecrosis of the subarticular bone in a bulbous epiphysis. It affects the second metatarsal head, rarely the third. Young adults, especially women, are affected mostly. Pain at the metatarsophalangeal joint showing a bony lump. The enlarged head is palpable and tender. X-ray shows the head of the flattened and white. The neck thickness and the joint space apparently increased. Treatment: walking plaster or molded sandals can be applied. Operative synovectomy, debridement, and trimming of the metatarsal head can be advised. Hind foot arthritis, excluding the ankle. The triple complex refers to the subtalar, talocalcaneal, calcaneocuboid, and talonavicular joints. These joints are often affected by arthritis. Treatment options are limited, and if simple measures have failed in this situation, a fusion should be performed and considered. This kind of a fusion is not meant for diabetics and the smokers because uh, the union rate is quite low in smokers and diabetics. So before considering this kind of a procedure in diabetics and smoker, you should take a consent, a written consent beforehand before doing any sort of a fusion in this patient. Now moving on to Morton's neuroma and metatarsalgia. Metatarsalgia usually occurs secondary to joint problems or irritation of a nerve. Morton's neuroma is very painful condition in which most cases arises from compression of the common digital nerve. You have always also remember that common digital nerve is the culprit party in causing Morton's neuroma, and it's between the third and fourth metatarsal heads. Diagnosis is confirmed by ultrasound. Non-operative treatment includes advice about footwear, anorthosis, pre-metatarsal dome to splay the metatarsal head, or an injection of steroid and local anesthetic can be advised. Surgery in this case involves resection of the affected toe's head, but it causes permanently or partially at times numbing of the nerve if removed. Rheumatological presentation in the foot. The early presentation of the rheumatological disease may be synovitis of the lesser metatarsophalangeal joints and widespread small joint disease, often in association with enthesopathy such as plantar fasciitis or Achilles tendonitis. However, the classic deformity of helix valgus with or without helix rigidex deformity and subluxation or even dislocation of the lesser metatarsophalangeal joints can be seen. So it's very much a complex kind of a deformity there. Ruptured Achilles tendon, more frequently seen in 40 to 50-year-old people who are undertaking vigorous sports after a long period away from such activities, uh, initiating uh, unknown or unaccustomed sporting activity after prolonged period can rupture Achilles tendon. Study have shown that elderly patients with Achilles rupture regain 70 to 90% of normal power with no treatment. So this is a good news that it can be cured without any treatment conservatively. Non-operative treatment option includes sprung ankle, AFO, ankle foot orthosis, or ankle brace. Surgery may be required in some cases where repair and augmentation may be required. Diabetic foot and Charcot joint. Diabetics have foot problems, as we all know, secondary to neuropathies and microvascular changes. They are at risk of infection and ulceration, and trauma, sometimes trivial trauma, can cause these ulcerations. It can lead to collapse of the foot, also known as Charcot neuropathy. Here you can see in these x-rays deformed and collapsed bones and their joints. These are different kinds of x-rays: a normal x-ray, march fracture, which is also a hairline fracture. It's seen in marchers, troops, and um, people who are regularly marching, especially on hard surfaces. Uh, Splinted toes can be seen. These marcher fractures can be treated as splinted toes. And then there is an interesting dislocation fracture, Lees Frank dislocation, which causes disruption between the medial cuneiform and base of the second metatarsal, disruption of the metaphalangeal joint, tarsometatarsal joint. And here you can see avascular necrosis of the talus, Chopard dislocation. This is a Chopard dislocation between midfoot and hindfoot. Tarsal navicular trauma, stress trauma. These are all pictures of trauma. So these are all the slides about deformities of the ankle and feet. Any question there? Questions are welcomed. क्या हो गया है?
नीचे रॉकेट है ये आपकी स्क्रीन शेयर कट हुई है
क्या हो गया इसमें?
हाँ जी, स्टूडेंट्स के क्वेश्चन कहाँ पे हैं? स्टूडेंट्स के क्वेश्चन कहाँ पे हैं? हाँ, मुझे वो पेज दिखाओ, स्टूडेंट कहीं क्वेश्चन कर रहे हैं या कोई नहीं कर रहे? ओके कर दो, हो गया? हाँ, मुकम्मल कंप्लीट हो गई। इसको जरा साइड पे कर दो। हैं?
स्टूडेंट्स को अनम्यूट कर दे सर।
कहाँ पे है?
स्टूडेंट है जो अनम्यूट कर दे रहे,
हाँ, अनम्यूट कर दो ना।
सारे स्टूडेंटों का है यार।
कहाँ पे है, दिखाओ ना मुझे। मुझे
हम करेंगे वहाँ से।
अच्छा, मुझे सारे दिखाओ पहले। कर दो, अनम्यूट कर दो।
सारे देख ले फिर वो
कर दो अनम्यूट।
कौन रूट और है यार खान
हैं? मुझे आवाज़ें तो आ रही हैं ना। हाँ जी, any questions regarding ankle foot deformities?
बात करेंगे
Any questions?
मेरे से देख
मेरी वो कर दो, मेरी वीडियो